Hi there, my name is Jen and I'm a student at Athabasca University studying towards my master's in nursing. I currently work as a community addictions nurse and I work very closely with the professionals from the opioid replacement therapy program. The program is offered in many provinces, including where I live, which is Prince Edward Island. In PEI, the program was developed to help stabilize the lives of opioid-dependent users while reducing the harm related to their drug use. The program has a medical team consisting of RNs, medical doctors, social workers, and therapists. They promote wellness by administering methadone or buprenorphine, which are legal drugs to help eliminate or reduce cravings without causing the adverse effects such as the intoxicating high. Methadone is becoming increasingly more popular as a treatment drug among the opioid-dependent population. Currently, the National Institute of Health recommends methadone as a standard of care for pregnant women who are opioid dependent. They claim that both mother and baby do best if started and kept on methadone, but as a community addictions nurse, I believe it's important to understand the possible adverse effects methadone may have on the baby and also be aware of other treatment options that are becoming more readily available, such as buprenorphine. In the last 10 years, there has been a shocking 242% increase in the number of babies born with neonatal opioid withdrawal symptoms. 30% of pregnancies in northwestern Ontario are affected by opioid use. In the United States, the prevalence of opioid abuse in pregnant women more than doubled between 1998 and 2011. And in an Ontario study, the number of infants born to opioid-dependent women rose from 46 in 2002 to 800 in 2014, with 58% of neonates showing symptoms of neonatal abstinence syndrome. All of these stats lead to the formation of my PICO question. How does taking methadone as a treatment option for opioid dependent in pregnant women affect the baby as compared to buprenorphine? The evidence presented and appraised reached the same conclusion and suggested that both methadone and buprenorphine are acceptable intervention drugs to manage opioid dependence in pregnant women. While some articles suggested that buprenorphine had a slight advantage over methadone in relation to the size of the baby at birth, most withdrawal symptoms exhibited in babies were the same with methadone exposures and buprenorphine exposures. While the effects on the baby still need to be researched further, the evidence does support the administration of buprenorphine as a treatment option for opioid-dependent pregnant women, but does not support my research question that there are different effects on the baby depending what medication the mother takes. This leads to my intervention, an educational intervention in form of 1-hour PowerPoint presentation to professionals working within the opioid replacement therapy program. Using the principles of learning and the adult learning theory, I will present the findings from the critical analysis and also explain the considerations such as cost effectiveness and accessibility for selecting which drug is prescribed. 2 different times will be available to sign up for the presentation, and I will provide time for discussion and questions. My goal from this intervention is to stimulate discussion surrounding treatment plans for opioid-dependent pregnant women and maybe someday have buprenorphine inducted into such treatment plans.